Thank you for staying. My name is Sunnie Kim. I'm a GI medical oncologist at University of Colorado. I actually really focus on upper GI cancers, gastric and esophageal cancer, but as a GI med onc, it's really inescapable, this young onset colorectal cancer. So thank you for inviting me to talk about this very important topic. So our agenda today, we'll discuss epidemiology, known risk factors, then the clinical presentation, biology, and issues unique to this early onset colorectal cancer, and then we'll review management for this population screening and some future directions. So let's start with some good news. The incidence of colorectal cancer overall is decreasing. If you look over here, though this is in the older population, 50 to 64 years old, and on the bottom, 65 plus. And so we're doing a good job. Well, it's better in that population. However, we are seeing an increase in the younger population. So as you can see, these are patients in the 24 to 49-year-old range. Unfortunately, this is the equivalent of 49 new diagnoses per day. And then the mortality, as you can see, it's really starting to track up. And I'm sure you've heard these statistics, but by 2030, colorectal cancer will be the #1 cancer-causing, cancer-related death in young people ages 20 to 49. And when we look by birth cohort, really starting around 1960, we're seeing that incidence go up sharply. When we break it down further by ages, it's frightening. You see that blue diamond, the 20 to 34 age range, it is going up very quickly, 90% in colon cancer and 124% in rectal cancer. And that's usually what we see in our clinics, that kind of left-sided colorectal cancer, especially in patients who have no genetic predisposition for this cancer. In the U.S., on the left, on the left, 2001 to 2005, we saw these increases, but by about 10 years later, we're seeing it really jump, and we're seeing most of the incidence increase in the Southeast, unfortunately. And then globally, it has become more of a global disease, especially in our Western countries. But the dark blue, it's kind of invading into these other countries as well. And so this is becoming really a worldwide issue. So what are the risk factors? For early onset colorectal cancer, about 25% of cases are related to some inherited hereditary colorectal cancer syndrome, with Lynch syndrome being the most common. And so hopefully, when the cancer is being diagnosed, they're doing reflex mismatch repair protein testing to identify patients who may have this disease due to inherited condition. And then 30% of early onset colorectal cancer patients have a first-degree relative with this cancer as well. And this is in comparison to all patients with CRC, where the genetic related colorectal cancer is less at 10 to 15%. So for our young patients, we have genetic testing recommendations. The NCC recommends to do a genetic risk counseling and evaluation for all persons with early onset colorectal cancer. So what are the risk factors for sporadic non-genetic colorectal cancer? It's not an easy answer, as I'm sure you all know. And I won't read through all of this, but on the bottom over there, these are some of the risk factors, some known than other. So lifestyle, the way we eat. Starting in 1960, 1970, a lot of our food was much more processed and manufactured, really going away from the whole foods and natural foods that, generations prior had been used to. Our diet is increased in sugar, red meat, fast food, ultra-processed foods. People have become more sedentary, more obese. I think now we are more aware of the risk of alcohol as a carcinogen, but I know as a med student, I was drinking a lot and I had no idea that it was a carcinogen. Medications, I think the big thing is we're learning more about the use of early age antibiotic use. I think our doctors are doing a better job doing antibiotic stewardship. And then also like agricultural runoff, industrial pollution, which are issues. And all these risk factors may affect our gut microbiome. It causes a potential dysbiosis of the gut microbiome. And these may, in turn, cause inflammation, pro-inflammatory markers, which can be a good environment for carcinogenesis. So what can we do? There have been some meta-analysis about the food and beverages we consume and their protective or increased risk of CRC. So protective, whole grains, protective. Fish, dairy, these may be helpful. Things that don't help, red and processed meats, red meats, alcohol to some extent. I'm always very pleased when I see that coffee is okay, so we're good with that. And then just going into obesity, there have been several studies looking at the association of obesity with early onset colorectal cancer. This was a nurse's health study too, looking at patients 25 to 42 years of age, tracked between 1989 to 2011. And there were 114 cases of early onset colorectal cancer. And we found that the patients with the highest BMI greater than or equal to 30 were at the highest risk of developing colorectal cancer. Also, they looked at, changes in weight from the age of 18 as they got older. And as there was an increase of weight, there was also an increase of risk of developing colorectal cancer. This was looking at men and the changes in weight from childhood to adulthood. So for the patients who were normal weight at early age and into early adulthood, and the patients who started overweight but lost weight and became normal weight, those patients didn't have an increased risk of developing colorectal cancer. But for people who were normal weight, became overweight, or were overweight, from a young age on, their risk was increased. The story about antibiotic use and colon cancer risk, I think, is muddled. This was a matched case control study in the UK between the years of 1989 to 2012. There were 29,000 cases of CRC versus 137 controls. And they found that there was an increased risk of antibiotic use with penicillins, but not cephalosporins, macrolides, or Bactrim. And so these are, I think, subtleties that I wasn't really aware of until I dug into this literature. And then it seems to maybe even have a protective effect in the rectum. And, we do see a lot of young patients have rectal cancer. So I think the data here is mixed. I think it's general good practice to avoid any unnecessary antibiotics, especially from early life and on. And then I'm not going to go through all these studies, but basically the factors associated with early onset colorectal cancer, we have conflicting data about antibiotics, about obesity, about alcohol. And so I don't think we fully know exactly what it is, but clearly something has changed since the 1960s, and it is a generational exposure. And so I know there's been a lot of talk about the effect of the gut microbiome and how that increases a person's risk for developing colorectal cancer. And this is also a very complicated field that I don't think we're going to get any answers anytime soon. Here we do have some individual bacteria that have been linked to CRC. And then we have also found that when you have an abundance of these bacteria, that also seems to perhaps increase your risk of CRC. And some thought is that it may not be the actual bacteria itself, but the bacteria that causes changes like DNA damage, DNA hypermethylation, other alterations in the mucosa that can also be a feeding ground for cancer development and growth. And so I think this is a nice schematic to just, again, highlight how complex the environmental factors are. There are factors that influence us at infancy, especially germline genetics, perhaps our sex. And then as we grow, we are exposed to various environmental issues like, diet, lifestyle, perhaps antibiotic use, and obviously obesity is a major issue. We hope that the GLP-1 agonist will really be able to reduce this trend, but there's still a lot we need to know about those drugs. And then, other risk factors like smoking and alcohol use. So what is a take-home point? It's complicated. There is no one early cause of early onset colorectal cancer. It's likely a combination of numerous factors. There is a very high interest in understanding the gut microbiome, what affects that, but these are complicated questions for which there are a lot of really smart researchers looking into it, but it's going to be hard to, I think, tease out. And then, there's a lot of association studies, but not enough causative studies, I think, as of yet. So the clinical presentation, this was performed by the Colorectal Cancer Alliance, and they looked at 884 patients and survivors. The median age was only 42, and the symptoms that really are associated with early onset colorectal cancer, these are really intuitive: blood and stool, abdominal pain, fatigue from anemia, presumably. And when in other surveys, really there's a knowledge gap. This was done in 2019, so we hope that things have improved since then. But of these patient survivors, 63% were not aware that CRC can occur in less than 50 years of age. As a result of this, 41% waited more than 6 months before seeking medical attention, and then patients had to get other opinions to be taken seriously about their symptoms. This was a study that was published in 2023 looking at the 4 key symptoms, and depending on which symptoms, how many symptoms, what was the time to diagnosis. And so, again, this is pretty intuitive, but if you have one symptom, the time to get diagnosed is 9.7 months on average. When you have 2 symptoms, it goes down to 5.8, and then 3 symptoms down to 4.8 months. And, I think the ones that really catch people's attention is rectal bleeding, maybe less so abdominal pain. We can kind of explain that away in a lot of situations. And then, are there any genomic differences, tumor-related genetic alterations between older and younger patients? There are some. This is a list of alterations that were investigated in patients younger than 40 years of age and then greater than equal to 50 years of age. And there are some differences, but it's not, I would say, as significant as we would like. But this is just interesting to note. And then, the question is, do younger patients have better survival? I think intuitively we would think that because patients are more fit, they can probably get more treatment options, but the data is not clear. For earlier stages, younger patients do a little bit better in certain studies. For later stages, younger patients do the same or worse than older patients with the same stage. And I think some of that is probably because younger patients present with more advanced disease, and there are delays in diagnosis, and they may have more aggressive tumor features. And so I think the most important thing we can do now is really focus on screening, who should get screening and when. There are a lot of groups that have put forth their recommendations. And I think this is older data, hopefully, too, but only 68% of eligible patients in the US actually undergo CRC screening. Barriers, lack of knowledge about the benefit of it, in some populations, just lack of access to a healthcare provider, reluctance, of course. And the rate of screening is lower in the populations that we would expect: uninsured patients, patients with low income who are, just trying to get through day to day. They're in the economic grind, and racial and ethnic minorities. So the American Cancer Society recommends that patients of average risk for colorectal cancer start screening at age 45. For patients 76 through 85, should be dependent on that person's overall health and their likelihood to live longer. And then people over 85 should no longer get colorectal cancer screening. I'm turning 45 this year, and my friends are just annoyed at me because I'm constantly harassing them and posting it on my Instagram. But they'll thank me. And then what are the tests? So as you all know, colonoscopy is truly our gold standard. You can go in there, take out the precancerous polyps, but a lot of people don't like the idea of it. My sister-in-law, mother had colon cancer, and she asked me, does a colonoscopy hurt? And she's very smart. So, that's the kind of barriers that we're dealing with. So if someone is not gung-ho about a colonoscopy, there are stool-based tests. There are tests, there are tests to look for blood in the stool, the fecal immunochemical test, the guaiac-based fecal occult blood test. These have their own pitfalls. And then there's Cologuard, the multi-targeted stool DNA test that can be done. But if any of these are positive, then you're heading towards a colonoscopy. And then visual exams of the colon and rectum. We've mentioned colonoscopy. There's also this virtual colonoscopy too. But again, if you see something, then you have to, go through that prep and do it. And then FlexSig every 5 years is also an option too. The USPSTF has a grade A recommendation for patients, for adults 50 to 75 years of age. And for the younger population, it's a grade B recommendation. But from what I can see, I don't think there's been any major hurdles with insurance, fortunately, with 45 and older. And so what are the future directions? It was fun. I was able to kind of do a little bit of a search, and I know there's a group at Columbia. There's a scientist there who is looking to create what they call organoids, take tumor samples from patients, kind of recapitulate them in a petri dish, but have them not just be the individual cancer cells, but kind of have it form what a colon would look like, and be able to do testing on this and see, is there anything from a kind of a genetic alteration level that's different, perhaps something else in the structure of the colon that could be different, that separates young onset versus older onset colorectal cancer. But obviously this is really preliminary. We still have many years to go. But immediately, how do we optimize the care of patients with early onset colorectal cancer? I know that at some cancer centers in the country, they really have a dedicated early onset colorectal center where patients are kind of plugged in with multiple services. And so, in this patient population, they deal with a lot of issues. Fertility. These are people at the height of their career with young children. How do we address those issues? They may need, they'll probably need genetic counseling. And then there's a lot of mental and emotional well-being and psychosocial distress that these patients experience. And just trying to help them on a very holistic level, I think, is so important for this age group. And then I think we can't ignore the financial toxicities involved. I had a woman who was the breadwinner for the family, and her husband had, very generously decided to be kind of the house husband, and she developed stage 4 cancer. And I just can't imagine that upheaval in that family where he had to just change course and find a job and, pick that up. So we know that the financial toxicities are a big issue. We have a program at Colorado where we have people really dedicated to filling out paperwork related to disability, kind of helping people, work with their employer to take that time off, hopefully with the intention of going back to work. And so these are programs that I think are very important for these people in their 30s and 40s. So conclusions, we know that early onset colorectal cancer is rising in incidence. This is a worldwide trend, and a lot of this is left-sided. There is no one risk factor. We know diet, activity, perhaps antibiotic use. These are all risk factors. And then screening, 45 is a new 50. And if there's a family history, I would speak to the provider about even earlier screening. I think the gastroenterologists are really aware of this issue now, and they're much more willing to recommend a colonoscopy. And young patients need to have access to some kind of multidisciplinary team if possible, so they can deal with all the aspects of this horrible disease: medical, psychosocial, financial. And then, survivorship care. Once they're done with all this, their life changes. Their, their fertility, just how they interact with their spouse and their kids, all that changes and needs to be addressed. And then, of course, I think we know now you are never too young to be diagnosed with this disease. I shared this the last time I did this talk, but this is a couple who gets treated at my cancer center. The woman, she was treated by my colleague, Chris Liu, who was a colorectal cancer guru. Unfortunately, she passed about a year ago. Her husband also has stage 4 colon cancer too, and I'm treating him right now. And I don't know how long he's going to make it for, and they have this small child. Fortunately, the child has a very good plan after, he dies too. But, this is what we're battling right now. Just, people with young children at the height of their careers. And we'll do what we can right now, but there's a lot we need to do in the future. Thank you so much.